following episode is brought to you by the American Urological Association. The American Urological Association is accredited by the Accreditation Council for Continuing Medical Education to provide continuing medical education for physicians. For more information on how to claim CME credit or to view faculty disclosures, please visit the AUA University at auanet.org/university. Support for this episode has been provided by an independent educational grant from Alnylam Pharmaceuticals, Inc.
Good morning. My name is Jay Rahman, and I'm chair of the AUA's Office of Education and professor of urology at Penn State Health. It's my pleasure to host another episode in our educational podcast series, with this specific episode focusing on urinary stone disease. The title of this episode is specifically Complex Cases in Kidney Stone Disease, and it's my pleasure to host Dr. Kyle Wood. We've had the pleasure of having Dr. Wood on our programming before. He's Associate Professor of Urology at the University of Alabama in Birmingham. He's a Vice Chair of Research in the department and really has a practice that's very much enriched in stone disease, and as we'll get into a little bit, his sort of niche interest in some of the genetic and hereditary causes that can contribute to complex stone disease. So Kyle, as always really appreciate you doing these programs with us, and obviously we love tapping into your expertise sort of shamelessly.
Great. Thank you for having me, Jay. I'm excited.
So yeah, I think as we talked about, just for our listeners, maybe before we dive into some of the nuances, maybe just take us back to just like the 20,000 foot view, which is, I think, what most urologists will kind of start with, and then we'll maybe talk a little bit more in detail about some of the nuances. But I think what I'd love to get your thoughts just first and foremost is these patients that have either complex stones or maybe multiple stones. When should we be getting more testing, maybe metabolic testing, 24-hour urine testing? When should that occur? And then maybe we can talk a little bit about how that can inform us in turn about how to manage these patients. So who should get this testing? First-time stone former? Multiple time stone former? How many times is multiple? Just talk us through that.
Sure. I think we need to think about stone disease as a chronic condition. And I think when we start to think about it as a chronic condition, we'll start to think about how we're going to work them up and how we're going to treat them differently. And, unfortunately, stone disease is often treated as an episodic event. They present with an acute pain, we treat their stone, and then it's almost like a good luck until we see you again. And if we start thinking about it as a chronic condition, we begin to look at what's causing the kidney stones and how can we prevent the kidney stones. Based on the AUA guidelines, if we're following the guidelines, really any recurrent stone former should be offered a metabolic workup. And if you're a first-time stone former who's interested, you should be offered a metabolic workup. And so if you look at those two categories, there are not too many people after having an acute event that would say that they don't want to prevent a future stone. So pretty much any stone former, I think, warrants at least an offering of a workup. And when we say a workup, we're really referring about the offering of 24-hour urines to collect and look at the metabolic profile, and then some lab work. In reference to the lab work, you want to look at whether they have high calcium in their serum, which may point to like a parathyroid issue. You want to look at some of their electrolytes, their renal function. And then the 24-hour urine is going to be really key. I mean, obviously, there's a lot of issues with 24-hour urines. There's compliance issues. The patients may not complete the 24-hour urine. And even if they collect the 24-hour urine, it may be inaccurate, maybe an overcollection or an undercollection. But let's just assume we get a good 24-hour urine. There's a lot of key data in there. Some of it has to do with dietary factors, and then some of it has to do with renal handling and kidney handling of certain molecules. But if you look at the dietary factors, there is, baseline advice that's all in the guidelines that we should be doing for our patients. But it's really about fluid intake, right? So we can increase urine volume and dilute out the bad molecules. It's telling them to watch their sodium intake. Unfortunately, for most Americans, we do have high salt intake in our diet, and that can result in high calcium in our urine. And so really counseling individuals on a low salt diet becomes important. And then, we all know about oxalate and citrate. So if we look at low citrate, we think about their stone composition, say it's calcium oxalate or it's uric acid stones. They may benefit from alkalization therapy. And then if they have high oxalate, we start to think about where's that oxalate coming from? Is it a dietary source? Is it some dietary indiscretion in high oxalate foods? Or is there some underlying condition? So in there, it can be an endogenous production, the body's creation of oxalate, or it can be an enteric issue, some bowel issue. If they have gastric bypass, if they have Crohn's disease, if they have ulcerative colitis, there may be some underlying pathology that's resulting in malabsorption and high oxalate. And so, to get back to your question, I think the key is to get that metabolic workup for stone formers, because then we can start offering the tools in our toolbox. And that's, we have pharmacological therapies. We have, just coming off the no stone trial. So we have data regarding thiazides. Now, unfortunately, or, it's just the way data is, but unfortunately, the no stone trial showed no decreased stone events. But if you look into detail into that study, it does suggest that thiazides, it works. It lowers your calcium in your urine. And if you look at some of the composite data and the imaging data, it did decrease stone volume. And so if we go out beyond 3 years, we may actually see a benefit to the thiazides. And so I think especially in our individuals that have comorbidities with, say, hypertension, there may be a good opportunity to treat two diseases, stone disease and their hypertension, and get the benefit of it.
Sure. So, few real practical questions as we talk about this metabolic workup. From a blood perspective, serum perspective, BMP with calcium, right out of the gate, is there anything else that's really needed, or is that sort of a reasonable starting point to assess for sort of the big ticket items?
Yeah, I think you can draw a lot of information. BMP is that's probably where we should start, right? From that information, you can glean a lot. You can see their baseline renal function, right? So you have their GFR, and you have electrolyte data. So it may point to some underlying condition. Say they have high urinary pH, and then they have some electrolytes. It may point you towards like a renal tubular acidosis diagnosis. That's really where we should start.
Got
it.
The
calcium level helps, because the calcium, if it's elevated, may point to parathyroid issues.
And then with the urinary measures, just talk us through. So you mentioned if you pH, calcium, oxalate, citrate. What else? Like magnesium, phosphorus? I mean, what are the ones that we should be looking at there?
Yeah. So I think all of us, when we order 24-hour urines, they do come in differently based on the vendor that we're using for our 24-hour urine. But if you look at, say, some of the vendors that kind of break it out into dietary factors and then break it out into stone risk factors, I kind of like that approach, because you have what looks like the dietary factors. So as you're pointing out, you may have the sodium. So you'll have sodium, you'll have chloride. And part of that's knowing that the sodium's actually coming from salt, right? So if they have sodium and the chloride don't match up, maybe they're on sodium bicarb or some other medical therapy. And then you can look at magnesium. Magnesium has been shown that if you have higher magnesium, that you're receiving supplemental magnesium, it may decrease your risk of stone disease. So we can look at the magnesium, and if they appear to be low and say their serum magnesium low, you can think about supplementing them with magnesium. It also, all of those, the dietary contributors, the magnesium, the chlorides, the calcium, the phosphorus, all are suggestive of what's going on with their bowels and their handling, and also their dietary approaches. So you can get a lot from understanding if they have some malabsorptive conditions from looking at that. And what their diet's like. If they have high protein intake, you may see the urea nitrogen up, you may see their phosphorus up, you may see their sulfate up. And that all may be pointing to a dietary indiscretion with high protein intake. And that can lead you, if they have, say, low urine pH in that setting and calcium oxalate stones, you may be advising them to decrease their protein intake to try to help prevent future stone events. And then the other factors, as you pointed out, you have your standard factors, your volume that you're always looking at, and increasing volume. You have your calcium. And tied to calcium is looking at the sodium intake again. But if you have hypercalciuria, you're going to advise them to decrease their salt intake. And then sometimes it's just the way the kidneys handle the calcium. And that's where the thiazides could come in handy if they have hypercalciuria without an underlying cause. And then oxalate levels, as you pointed out, citrate levels, and then looking at urea nitrogen levels and uric acid levels. And then the pH of the urine, because obviously pH drives a lot of our stone disease, in particular uric acid stones, right? Uric acid is a pH issue. They have low urinary pH and uric acid stones. They're going to benefit from alkalization.
So what's the value in, let's say you have a recurrent stone former and you have a 24-hour urinalysis study and it looks underwhelming, right? I mean, nothing's really jumping out. And I think about this a lot, you know, in the folks that do, like in my practice, who do a lot of BPH, and they get flow rates and PVRs. And sometimes the flow rate in the PVR looks pretty good, but the clinical story doesn't tie into that. So, and in that regard, they'll say, you know, maybe we need to repeat that because that single measurement may not have been an accurate reflection. Maybe talk to me a little bit about the value, you know, of a repeat 24-hour urine. If the story kind of smells funny, but the testing doesn't seem to jive with that. Talk about that.
Yeah, Jay, you're making a great point because it's just a snapshot in time. The 24-hour urine is one representative time frame for somebody that has, you know, 365 days a year of dietary choices and lifestyle choices. So the 24-hour urine, repeating it becomes important. Even at baseline, getting 2 24-hour urines. I think there's a lot of thought that can go into it. One is some of our patients that do 24-hour urines, we've already given them their dietary advice. We've already told them this is how you prevent stones. And then so suddenly you sort of see the stone clinic effect on their 24-hour urine because they're like, they're not cheating, but they're cheating for the test. They know what we're going to be looking at. And so you have to put it in that framework. I think, you know, obviously most of us, if we're working regular shifts like weekday and then having weekends off, our dietary habits can change drastically throughout the week. So even considering individuals, if they have, say, a normal 24-hour urine during the weekday that they're collecting, maybe talking to them about doing one on the weekend where their dietary indiscretions may increase. Or so getting repeat ones becomes important because it really does show over time, what does their 24-hour urines look like and what are the contributing factors to their stone disease? And at the end of the day, the 24-hour urine is just a list of molecules that we're measuring. But there are other causes of stone disease that we just don't have the capability of measuring now. There are inhibitors of stones that reside in the urine that we're not measuring. So even if we're not detecting something, there may be some underlying cause for their stones that we're just not capable of measuring in today's 24-hour urines. And so we have to, it's not to say, I still think, and I always tell my patients, it's just about moving the bar. If you are a recurrent stone former and your 24-hour urines are quote unquote normal, it doesn't mean we don't tackle some of the trying to decrease it to say low normal. So for calcium, or, you know, decreasing their salt intake, increasing their fluid intake. You gain benefits from each of those parameters that we try to manipulate, even if they're quote unquote normal. And so that's taking in, just like the BPH clinical scenario, it's taking in the clinical scenario. If somebody has recurrent stone disease, you're still going to tackle some of those things, even if they're quote unquote normal. Right. And you're going to go to the low hanging fruit.
So when should we be thinking about getting like a nephrologist involved? So yeah, I think let's just take, you know, you and I both work in academic practices. So we often will have persons who are very uniquely interested in this space and who have practices that are really, and often in academics focused in niche areas and therefore not only the medical, but the surgical aspects. But as one goes out into maybe a broader clinical practice, and you don't do as much of this. When should we be partnering up? How do we partner up? What's that relationship with a nephrologist who may help with maybe some of the interpretation of these studies and maybe the complement being like the dietary element there to affect change?
Yeah, I think, you know, getting others involved is always helpful. So I think we take our patients, and most of us in our clinical practice, whether we have an academic practice or a community-based practice, we know when something's not right, right? We look at our stone
Hmm.
formers, they're coming in all the time. They're seeing us twice a year. They're having their procedures and they're miserable with that's, I think, when we say, okay, look, we're going to get some help for you. And nephrology is a good colleague to have. They embark on these metabolic and dietary workup and management for our patients. And so I think we can always call on them to help. There are, as you pointed out, Jay, there's a lot of academic centers that have stone clinics that are multidisciplinary. And also there are urologists like myself that are focused on this as well. So there's always the opportunity to refer to us as well and allow us to take care of the dietary and medical workup and work on those patients, kind of optimize their treatment, and then have them come back to our other urology colleagues to kind of manage their stone events as they come up. So I think there's a lot of opportunity there. But again, the nephrologists are key to this. I think when it comes, as you can see, as we talk about the nuances of 24-hour urines and the metabolic workup, it can get quite difficult. And you actually have to be managing their medications and the side
Hmm.
effects of the medications. And I think in those scenarios, in our busy clinical practices, it may be difficult to embark on that stuff. And that's where a nephrologist comes in handy, especially as we all know, a lot of our stone formers have a number of medical comorbidities and our polypharmacy. So the idea of adding in another medication, say like potassium citrate, and they have an ACE inhibitor on board, and we're
Right,
worried
right.
about managing their potassium, or they're already on 3 hypertensive medications and we're
Hmm.
talking about adding a thiazide. That's what nephrology does. They manage those drugs already. So it kind of makes sense to get them involved and to allow them to work out optimizing those therapies for our patients.
So probably in the last maybe 10 years plus, if you look in the oncology world, there's a much greater appreciation for the genetic basis of malignancy and hereditary factors. And I know this is an area for urinary stone disease you're obviously very passionate about, and we'll include it at the end, the article that you recently wrote, so that our listeners can get a chance to sort of take a deep dive into it. But I'm going to pivot it a little bit now and ask you a little bit about these patients that maybe are complex stone formers, recurrent stone formers. What are sort of the indications that we should be thinking, hey, maybe this person needs genetic testing, and what does that entail really? So talk to us a little bit about that.
Sure. Yeah, I think we have patients that come into our clinic where we know something's not right. Again,
Hmm.
they've started. I think some of the key things to be looking out for is if they had early onset of stone disease. So if you see them in the office and they say, yeah, I had my first stone as a pediatric patient, I think that's clearly a sign that something's not right. And they may have never had a workup. And so that is a key to consider genetic testing. Strong family history. Most of the monogenetic stone conditions are autosomal recessive, but there are some autosomal dominant. So if you see a strong family history of stone disease, if you have siblings with stone disease that have genetic conditions, that's a no-brainer, right? Like siblings where the siblings known to have, say, primary hyperoxaluria type 1, you should be testing the other siblings in that scenario. High stone burden. We've had those patients come in, they have their CT scan and they have like bilateral staghorn stones and they're just full and they're not infectious. They're calcium oxalate.
Hmm.
That's something that may trigger us to think about a genetic workup. If they have underlying CKD, so you have CKD in a lot of stones, so you have chronic kidney disease, that may be another scenario where we should consider it. And then these highly recurrent stone formers that just continue to form stones, that may point to an opportunity to consider genetic testing. Genetic testing, as happened in a lot of fields, including stone disease now, it's changed. The environment's changed. The next generation sequencing has made it cheaper, so it's now affordable. It's quick turnaround, and it can be really done in the office with buccal swabs.
Hmm.
And so the advantage we've had in the stone world right now is we have genetic testing being offered through various vendors that's being covered by industry sponsors. Now, the industry is completely disconnected from the actual genetic testing and the results. They don't get any access to it, but what they're trying to do is offer more genetic testing to our stone formers. And so that's created a unique opportunity because it's free of charge for our stone formers. And so, and it's a buccal swab. You can get blood, but buccal swab seems to be the preferred method for our patients because it's a simple swab. So I think
it's a buccal swab that you can do in the office, and then at present, the cost of it is covered, as you alluded to, by sort of industry support. Is that right?
Correct. Yeah. And so, if we're obviously there's other routes to go and get genetic testing. So you can, Mayo Clinic still offers a genetic profile test. You can use Natera, which is, a genetic platform that has, a 200 and something gene panel. But if you're looking at a cost-effective way to do it, there's multiple platforms now offered through industry where you can get the genetic testing done. Most of them reside around a 45 gene panel that are all associated with monogenetic causes of stone disease. And so it's really going after the ones that we are associating with stone disease. And so it's not all inclusive. I mean, as we know, genetics are evolving, and our genetic understanding of stone disease is certainly evolving. And so we have a panel that is representative of the data that's out there now and the genes that are associated with stone disease.
And so, and this may be a hard question because I'm sure one doesn't really know what the true denominator is, but do you have a sense, you seem to have a practice, maybe it's a little bit skewed because it's a referral practice, but what percentage, do you broadly quote, when you're talking to these patients who have bilateral nephrolithiasis, or they have this sort of compelling story, the stones early, family history, what do you broadly quote them as the risk of having a genetic or hereditary mutation? 10%? 5%? I don't know.
Yeah, I think this is where we need more data to be published on this. But if if we talk about our experience at University of Alabama, we're looking at about 5 to 10% finding an underlying cause that explains their stone disease. Now, I think it gets a little bit complex because there are a lot of what we call variants of unknown significance showing up. So we have gene mutations that are showing up in some of these genes, and we don't know if they're pathologic or not. And so I think that's where it gets a little complex. And this is where, referring to a referral center or getting genetic counseling involved and a multidisciplinary approach needs to be done, and where you tie in those other parameters. So say you have a mutation in a gene that regulates calcium, and it's a variant of unknown significance, but on 24-hour urines, they have severe hypercalciuria. You're probably going to think that variant of unknown significance is pathologic, and that's what's causing their underlying condition. So for us, it's about 5 to 10%. And, I want the, listeners to understand that even when we talk about 5 to 10%, you may be going, some individuals might be going, well, that's fairly low. We got to remember, a lot of these are conditions that we can intervene on. And there are therapies out there, and also getting a lot of them may lead to chronic kidney disease. So getting that multidisciplinary approach may actually add years to their kidney life and may add, and we can reduce their stone disease. And for a lot of our patients, there's a level of frustration because of the number of contacts they've had in the healthcare system through the emergency room, through the emergency room, through primary care, through urologists, nephrologists. They've had so many contact points for their stone disease, and they've never had an answer. And so we give them an answer, and we give them treatment options.
And truth be told, 5 to 10. If you look at prostate cancer guidelines, kidney cancer guidelines, all of which have genetic testing in the guidelines, the rates are about the same. To be perfectly honest, they're about 5 to 10%. And again, I think the point you made, which is that these are potentially personalized, targetable factors that can have a significant bearing on, in this case, for example, long-term retention of kidney function, decreasing number of stone events, as opposed to sort of the blanket, statements where you don't know they have this, which is, drink more fluids, cut the salt down, which may not be wholly appropriate in every circumstance. So talk to me a little bit. We've talked theoretically about genetic testing. Talk to us a little bit maybe about a case study in part, like one disease process, like primary hyperoxaluria type 1. Talk to us about how we can use genetic testing to maybe identify something like this and then sort of the pathophysiology, because I think this is sort of a case in point of maybe the spin-off of why genetic testing has value. Talk to us about that.
Yeah, I think so. Primary hyperoxaluria type 1 is an interesting study, like to look at disease state, because we now have treatment options for these individuals, and the treatments have been quite profound. They've changed the landscape for these patients suffering from this disease, because we can reduce their urinary oxalates by upwards of 50-60%, and it's preserving their renal function, it's decreasing their stone events, it's preventing nephrocalcinosis. And so there's so many benefits to these the new drugs that are out there. And one was approved in 2020, and then the other one was approved a few years later. And so we have now two treatments. And so again, to your point, Jay, but now we have treatments for these diseases. So now we got to find these individuals so we can change their course. We all learn in our urology residency and in the core curriculum, primary hyperoxaluria type 1. Prior to these treatments, really the curative treatment was a liver kidney transplant. So we were giving the kidney transplant to, because they all were presenting with renal failure, and then the liver to change the underlying mutations that are occurring that are resulting in increased endogenous oxalate. So when we talk about the pathophysiology, primary hyperoxaluria, there's three types: type 1, type 2, and type 3, and they all have mutations in genes that are involved in detoxifying glyoxylate, which is the main precursor to oxalate. And so when we have mutations in those genes, the result is an increase in oxalate production by the body, and that oxalate has to go somewhere. So it's seen in our urinary, in our urine, because it's renally excreted, and so that results in stone disease, but it's also resulting in nephrocalcinosis. And then also that oxalate builds up in our bodies if you have primary hyperoxaluria type 1, 2, or 3. And then it can result in what's called systemic oxalosis. Basically, oxalates gets deposited in multiple organs and can result in all these organs to fail. And so the presentation for a lot of our primary hyperoxaluria patients is really early on. So it's a pediatric presentation in general. That being said, that's partly because we weren't testing our patients. They were presenting, and then we were thinking about the disease instead of working up patients. So in my practice, I've found 3 adult patients with primary hyperoxaluria type 1 that were presenting with multiple stones, like we were talking about earlier, these recurrent stone disease, high stone burden kind of scenarios, where they weren't really severe disease, meaning end-stage renal disease at the age of 7 or 8, but they were presenting with a recurrent stone disease. So I think that it opens up an opportunity to think about, are we missing some of these diagnoses? If you look at the just whole genome sequencing, the prevalence of primary hyperoxaluria type 1 should be roughly 1 in 58,000 individuals. In the United States, we only have diagnosed 1 in a million. So there's a disconnect, and that disconnect can be genotype, phenotype presentations and stuff. And so maybe not everybody with the mutations are going to have a phenotypic presentation, but it clearly shows that there's some disconnect in what we think about the genetic, what should be the genetic prevalence of it and what we're seeing in the United States. And so I think that does suggest there's a disconnect and there's misdiagnosis or underdiagnosis of that primary hyperoxaluria type 1. But for primary hyperoxaluria type 1, it explains right now a large amount of our pediatric patients that have chronic kidney disease or nephrocalcinosis. So it is, not common, but it also can cause pretty severe disease. So the delay to diagnosis can be upwards of, on average, 6 years, if you look at the Mayo Clinic registry data. So clearly there's an opportunity in the healthcare professions to get an earlier diagnosis for these individuals. And so when we're spotlighting primary hyperoxaluria type 1, it's really trying to find individuals that may have this. Part of it is if they're collecting 24-hour urines, which some pediatric patients cannot, because they're not potty trained, they're not going to be able to collect 24-hour urine. So you can get spot urines there. But if they have hyperoxaluria and they have some stone disease and they're presenting as a pediatric patient, we need to consider primary hyperoxaluria type 1, as well as the other ones. And that's where genetic testing can come in handy.
And just talk to, genetic testing allows you to identify this. I think you mentioned it, but in addition to identifying it, now do we have the capacity for therapy? And just give us a sense of like what is that therapy? Like, okay, now we've done genetic testing, we've identified, say, a 10-year-old who has primary hyperoxaluria type 1. Now what?
Yeah. And I think that, there are new therapies that I'll talk about, but we still need to use our basic therapies as well. And the basic therapies for primary hyperoxaluria type 1 and 2 and 3, but is really hyperhydration, right? We got to stick to the principles. So you encourage them to have a lot of fluid intake. You can come in with potassium citrate to alkalize and to give citrate, inhibitor of stone disease. And then for certain primary hyperoxaluria type 1s that have genetic mutations that result in the enzyme not locating appropriately to its compartment. So it's a certain subset of these individuals. They benefit from pyridoxine or vitamin B6. And so we all kind of remember that from our in-services and stuff. What it is it's a cofactor for the enzyme. It allows for stabilization of the enzyme in these certain mutations and allows it to localize appropriately and function appropriately. So we still need to consider pyridoxine treatment in certain individuals. But the landscape, as I said, has changed. There are 2 drugs out there. They're both RNA interference therapy. They're given subcutaneously. They're at different dosing frequency. One is, a quarterly dose once you get on maintenance therapy, and the other one's a monthly dose. But it's really just a subcutaneous injection. And it can be delivered, at home or in the hospital setting. But again, you're having individuals that prior to this were put on the therapies that the hyperhydration, the pyridoxine, and we were trying to just prevent renal function issues and trying to preserve their renal, and then they would eventually get a kidney liver transplant. Now that's changed. Now we can give these, so the 2 drugs are lumasiran and nadasaran, and they're again RNA interference therapies, and the data, it changes everything because the data shows a significant reduction in urinary oxalate, talking on the order of 50-60% for most individuals. And then in addition, you have reduction in stone events and you have reduction in nephrocalcinosis. And so you have clear data now that will show that they're going to clinically benefit. And, again, the first drug came out in 2020, so we have years worth of safety data. For most individuals, the only safety event is injection site reactions, right, which you kind of expect, pain that resolve just with, conservative treatments, and then increased abdominal pain, which we don't quite understand completely, but again, just treated conservatively in all of them. So it's a very well tolerated medication, and it allows for, prior, I think some of us that have been in the field a long time, if we came across a primary hyperoxaluria type 1 patient, we would send them, be like, you have to go to Mayo Clinic, because that was really the center for rare stone disease, and they knew it. But that landscape's changing. I think we can have our nephrology colleagues, the stone clinics like myself, that can manage these patients and manage the treatment now because of the therapies that are out there.
Yeah, I think that's a great example and a great sort of case study, because, when I asked you, and then what, I feel like it's nice to know there is a what, and meaning that it's not simply a matter of diagnosing this. And I think you made a really good point, which is we can't abandon sort of the core principles that you highlight, hyperhydration, for example. But the fact that there is some sort of personalized option, and obviously relatively new, right? I mean, in the last 5 years, but these are sort of really good examples of, if we're able to test for it and we're able to assay for it, and industry partners are able to develop therapies that target these areas, you're probably dramatically altering the arc of this individual person's journey with regards to recurrent stone formation and or decline of kidney or liver function over their lifetime, which is really enormous.
Yeah, I mean, it really has changed the outlook for these individuals. And so I think and again, that points to us needing to diagnose these individuals because we can get them on treatment. And it does, I think urologists play a huge role in that. If you look at a lot of the patients with primary hyperoxaluria type 1, they had multiple touch points with urology before diagnosis. And so it gives us a unique opportunity to intervene, test them, offer testing, or refer them for the testing.
Yeah.
And yeah.
I think what you just said, rings so true and is so similar to how we talk a lot about the role of urologists for example, genetic testing for prostate cancer, right? Because you are the touch point. If prostate cancer, urologist touch point, kidney stone disease, urologist at touch point. And if it doesn't occur to you, it may not happen. And so, it really does put the onus on us to think about some of those factors you talked about, which should be at least maybe your spidey sense should be tingling that, hey, something doesn't seem quite right here. And maybe this is a hereditary genetic associated kidney stone former, and at least go through the motions of it. And at that point, maybe you don't even know exactly what to do after that, but then, you tag in some friends, either at specialty centers of excellence or collaborating specialties to help you. But you don't know what you don't know unless you at least think about it and think about testing for it.
Yeah. And I think that's, I think there's a lot of apprehension to starting genetic testing programs. I think that's probably happened in the prostate cancer world, but in the stone world as urologists, because well, how do you interpret the data? I do want to point out that almost all of the programs have genetic counselors associated with them. So it's literally like a checkbox, and they can get pre-counseling, they can get post-counseling. So through the programs, you already have the genetic counselors involved. Mm-hmm. So, some of the apprehension that may be occurring in some urologists' mind, what do I do with these results, can kind of already be parsed out by these genetic counselors. And we've already involved them from the beginning with the testing. And then, as you said, calling in your friends. I mean, honestly, I'm always available. So, reaching out to these stone centers, referring them to the stone centers makes a lot of sense. And getting our nephrology colleagues involved and making sure that we're taking care of these patients. But I do want to make the point that being genetic testing it's a hard thing to embark on and think about, but it's with all of the help that's supported through these programs, it's something that can be integrated into practices. And I think it's, again, a point of care test that's done in the office. It's a buccal swab. It's got ease, affordability. So I think a lot of the barriers that we've had in the past for genetic testing have been put down. So
that's great. Well, Kyle, always a pleasure. It's always a great conversation. I always learn something, which is always a nice part of it. And I really do appreciate your time today in this podcast.
Great. Thank you, Jay.
For our listeners, thank you very much for joining us and tuning into this podcast. We will have it posted on AUA University, and we'll also have it, the reference that Dr. Wood authored with several others that sort of dives into this to a greater degree, and we'll have that tagged with that as well. Kyle, I hope you have a great day. Look forward to seeing you hopefully soon.
All right. Thank you, Jay. Thank you so much, everyone.